Yes, it's perfect.
Okay. I would like to say thanks to the organizer and giving me this opportunity to discuss on the screen time and uh, the what is its impact on the brain development of the children, and I will discuss about the cognitive, behavioral, and other neurobiological implication of the screen time, and then we'll end with the recommendations for researcher and multi-stakeholder will be the end part of this talk. So if we talk about the significant aspect of the screen time in behavior addiction, I will interchangeably using here the behavioral addiction and screen time uh, in one they can be interchangeably used here, and that the focus is on the screen time, because whenever we are talking about the screen time, all the technology related behavioral addiction get covered in it, whether we talk about the social media or talk about the gaming addiction, we talk about the other sort of technology addiction. So I will be focusing upon the screen time, and this will be the consideration for the um, audience here. Now if we see here the physical implications or complications of what is happening, what we are finding in the children's that and other population also, there are initial evidence of the adverse effect of excessive screen time on the brain structure and function of the children's also. This is even all the studies what I have gone through, what I have because it has been my interest area, I find that uh, even the factual conclusive evidences are not there. There is a mixed finding if we talk about the impact of the screen time on the brain development and growth of the children. But there are other studies also which are talking about these findings. Like if we talk about the other health parameters also being closely associated with the increased screen time. Suppose if you talk here, if you see here in this slide, we may say the low cholesterol, SDL cholesterol, obesity, cardiovascular disorder like hypertension, eye pain, back pain. These all studies are the shared finding of the coming slides also. And if we see here the psychiatric comorbidity among the individual who are uh, diagnosed with the internet addiction disorder, obviously here also the screen time is one of the important things associated, because without looking into the skin, the internet addicted individuals, we cannot assume of that phenomena also. If we see, these are the range of the disorder. Alcohol use disorder, the individuals, if we see 28% of them share the alcohol use disorders also, nicotine, stress, anxiety, depression. If you go down in this column, we see that they share quite other comorbidities in the percentage also are given here. And when we talk about the recent study which we conducted in our institute, and then we found that basically the 8% of the adolescent and children were associated or found to be addicted to the social media. Overall addiction level was 32%. It was around the sample size is written here. I am not able to see it, but you see this is the percentage of the individuals in Indian or adolescent and the children in Indian population who are going through this behavioral addiction and screen time phenomena. And similarly here, if we see another study, the adolescent, which is done under for the ample digitation, here also huge 32% of the individuals were found to be positive for the internet addiction, and the 27% pornography addiction, and the sample is around 800. I see I have mentioned there or not. Now you see what is this. Now the co-occurrence within the behavioral addictions itself, or co-occurrence within the behavioral addictions. If we see here, study addictions, shopping, gaming, Facebook, pornography, food addictions, they correlate with each other, and average co-occurrence is this in the last column. If we see, it is ranging from 10% to 18%, and overall 19%, around 20% of the individuals having this, co-occurrence. So it is demanding the attention of the researcher, and there are many aspects which I am not going to discuss in this regard. Now, what happens, that co-occurrence we have already discussed. Now, specifically, if we look into the cognitive, behavioral, and the neurobiological correlates of the screen time, which are the recently last 2-3 years studies across the world, and what they indicate, we will just discuss about it. More than 2 hours. This is a criterion for all of us here present here to look into, and to use its practical implication in our family also, along with the research further, which we can adopt, and try to find out the other associated things. So more than 2 hour screen time is associated with the poor language development. If we talk about the 2 years old children, this is a recent study in 2000, citation is there, and I hope if any audience want to extend the reading or understanding, they can go to the cited article. And screen time is associated with the sleep quality and sleep time. These all are the studies conducted in the child and adolescent populations. Now here also, if we see again sleep problems, these are the now, other than that, if we see the screen time is poorly related with the health quality of life and behavioral problems. Basically, internalizing behavioral problems are greater to be found when the screen time is going increase or increasing beyond the limit or beyond the given recommendations. And recommendation was that uh, then lower, this is very interesting finding, lower perceptual motor integration. Again, this is also a direct measure to see that how the skin time is affecting our cognition, our neuropsychological development. Now here we see lower perceptual motor integration. Those individuals who are excessively, those children who are excessively using the electronic gadgets, especially the smartphone, the screen time is affecting their perceptual, visual, as well as motor coordination, which is very important for the growth and development of the child cognitively and other aspects of the development. Then if we talk about here, another the study says that when the individual is exposed to the smartphone or multimedia tasking, and there's a positive association between the impulsivity and the multimedia requirement which we are doing whenever we are exposed to the smartphone, or we are using the screen for any kind of multitasking. It was found that it was inversely associated with the decision making, as well as positively associated with the impulsivity. So you see here cognitive flexibility and decision making, two important things for a child to develop and to grow, because we use the decision making in multiple aspects of our life, and impulsivity obviously is found in the children to some extent, but beyond the limit, it is harmful for their development and growth. And impulsivity is such a one trait that share the characteristics across the diagnostic spectrum. It is a trans-diagnostic phenomena. Then it was being, inversely associated with the multimedia tasking, multitasking, especially during the screen exposure. Then another study here says, the second one in this slide, that anxiety and depression are also the correlates of the high digital media use or high screen time use. Again, the age range here is here, the 6 to 17 years of children and adolescents. Similarly, if we see the below the third study in this, it says that the speech production for self-regulatory purposes in the adolescent was found to be affected by the increased, screen time production, screen time use, or increased smartphone use. Now you see here what we are seeing, and another one important study. Even this is the area we need to work, that the clinicians or the researcher across the discipline need to work upon how it is, bringing the change and the minute aspects of that, so then we can work upon the preventive aspects also, we can work upon the promotive aspects also. If we talk about curbing the effect of the screen media, and we know that, on other hand, we cannot control the children, because if we are engaged in the smartphones, or because many of the work, office tasks also is dependent upon the technology use. So there is, this area also need to be, understood or researched by the researcher in future also. But if we recently see what was 2022 study says that the higher digital media is associated with the lower cortical thickness in various regions of the brain, okay, which are supporting the higher order of processing in the preschool children. Now, this need to be further investigating. We can investigate it. Intense social media use is associated with the higher order of, you know, again, the physical activity. There is an inverse association between the activity done in the smartphone or screen time and the activity done in the physical activity, that is going to hinder the multi aspects. And I saw some of the studies are saying that the screen time is associated with the, diabetes, obesity, and other lifestyle problems in the children also. Even the studies are very less in the initial in state. Now again, the TikTok challenge poses an ophthalmological risk for the adolescent and children. Researchers are saying that the eye injury is happening, and vision problems are reported in the clinics by the children's as a result of the excessive screen time. Now, if we see here, what is the status of the research across the world on internet gaming and the gaming, because again, this is one of the major region for, using the smartphone or screen time among the children and adolescents. Now if we see here, if I talk about my country, even we have a lot of studies published in this particular area, if we talk about the smart screen time as well as the gaming and smartphone addiction. But here the data is that this region is saying that no prevalence data is available. So we need to think as a researcher why it is so, because we see a lot of researches are published, then why this BMC is not able to find, BMC authors, the articles are not able to find those studies. What are the things that we need to look into? And a lot of efforts are being done in Indian context, which I'm not going to discuss here because of the constraint of the time. Now, based upon the previous, aspects or the findings and the, what the researches are indicating, I will discuss briefly about the preventive and management aspects of these problems. Again, in the initial beginning of my presentation, I discussed that the screen time, smartphone will be taken together here. Basic emphasis on the smartphone. Now, these are the five-fold, recommendations or the five-fold suggestions that we can curb this problem better, and we can provide the ample opportunity for the growth and development to our children and adolescents. Because what is happening, I see that not only the children and adolescents nowadays, we just take a simple example. When we ask the people to calculate few numbers and derive into an answer, they just open the cell phone and start the calculating in the calculator. They are not using, we are not using our that mental operations which are used or needing to do such kind of manipulations, and which is very important for the healthy development of the cognitive functions. That is one simple example that what we are on the one hand, it is a kind of immense source of information for the human being as well as for the children and adolescents. But the drawback is, if we don't curb them, it is going to be affect the whole budget of the country, as well as it will have a poor outcome in terms of the many other aspects where we talk about the healthcare and promotive aspect. Now, what would be, there's a need for the public awareness and education, right? That what is happening, and print media, electronic media can play a bigger role in it. What they can do, they can talk or they can write the articles, and they can talk, call for a debate, discussions, and call for a platform where the youth and the parents can interact them. Or such kind of programs need to be periodically there in the platform, so that the individual get aware about, because the many of the parents are generally just know that the excessive smartphone is injurious for the development of my child, but they don't know what area is going to be affected. So these things need to be made aware to the public. And when we talk about the school based initiative, I basically, when we talk about this screen time and digital health, obviously it is a part of the mental health in our country. The awareness about the other mental health aspects is very low, and the overall suicide committed by the Indian student as per the NCRB data, was the 7% of the total committed suicide. The last the study they have done. So again, this is indicating that we need to look into the school and school-based mental health promotions. And we in the JSS are doing these initiatives, and we are getting the good result also. And later on, we can move into the curricular development, where the mental health aspects as well as the screen time and behavioral addiction awareness, preventive, and other informations can be put in the curriculum specifically. And then counseling, and we need to train the therapist and the counselors also, specifically uh, do's and don'ts for the behavioral addiction, especially the screen time, and that then they can help us to cater the larger number of individuals. And there's a need of the support groups like we have for the alcoholism anonymous. And similarly, there's a need for the behavioral addiction, and especially for the parents of the children who feel that their child is excessively involved. Excessive involvement means usually when we talk about, the researchers say that the children should not be exposed to any kind of such screen which emit these radioactive or these things. So we need to look into it. India has recently started the tele. We all are aware about it. And the behavioral addiction or screen time related issues can be the part of this tele activities. And people can be made aware about it. Whenever any kind of call they get, they must inquire about the behavioral addictions or smartphone engagement, and take a data on it, and assess the individual if anything needed to assist them. And similarly, the community engagement is required there. And for the parents, they need to be again, this parental awareness can be created by the media, as well as the school can play a important role here, especially devoting the specific time in the parent teacher meeting. We can discuss upon these things. And for the government and bureaucrats and decision makers, policy makers, I would recommend here that in the National Mental Health Survey, which will be happening, must include the behavioral addictions, uh, uh, especially the prevalence, risk factor, protective factor, because it was not a part of the last mental health survey which has happened between 2015 and 16, if I'm not wrong about the year of the conduction of this survey. Then we can have a nationwide data on the behavioral addictions and screen time overuse. Then we can that will help us to make the policies and to think the take the bigger decision. So this is what I would stop myself here and back to the organizer. And I will again thanks to them, all the whole team, for giving me this opportunity. Thank you so much, ma'am. Back to you.
I'll be presenting a case we saw some years ago, and it was very challenging for us at that time. So the content of my presentation would be regarding mainly the patient's history, the clinical evolution, what we did for investigations and workup, and how we managed the case, followed by a brief discussion of anti-MA2 encephalitis. In overview, the case is about a 50-year-old female patient who presented with olfactory hallucinations, nausea, hypersomnolence, as well as different types of seizures, including GTCs. We found anti-MA2 antibodies in serum tests. However, malignancy tests were always coming up negative. Pelvic CT showed us an surprising finding of absence of uterus and bilateral inguinal masses. So I'll take you through the journey we had over 2 to 3 years with this patient. The patient is 50-year-old, right-handed, and she's phenotypically female. She was known for primary infertility. For family history, she had different peoples in the family positive for neoplasms, including some uncles with the colon cancer, other family members with leukemia, and a person with a lung mass. Regarding her symptoms, she presented with progressive, varied neurologic symptoms. It started with recurrent olfactory hallucinations, typically bad smells. Within a month, she started having seizures, generalized tonic-clonic, or focal to bilateral tonic-clonic, and focal unaware seizures. Within 2 months, she started having recurrent episodic nausea, fear, social withdrawal. She became more isolated from the family. She was also having reduced appetite. At 6 months, she started having memory decline. And this impacted her because she was working as a teacher at that point. And she was starting to have mild cognitive impairment. This is when she presented to our facility. Prior to that, she was taken to different hospitals in the region to try to work her up. On physical examination, she had some abnormal vital findings, mainly tachycardia. There was also papilledema in her right eye and gaze-evoked nystagmus, as well as abnormal tandem gait, although she was able to walk unaided. This was her initial MRI brain in our facilities. And there is T2 flare hyperintensities, mainly in temporal lobes, bilaterally, as well as in the insular cortices here. For investigations, the basic labs initially were normal, and then she started having hyponatremia, as we attributed to SIADH. She had positive anti-MA2 antibodies. Other antibodies that were sent in serum and CSF were negative. Serum tumor markers remained unremarkable throughout our repeated testing. CSF showed elevated protein. There was normal glucose and cells. Imaging to look for malignancies were repeatedly negative, including colonoscopy, pan-CTs, ultrasound of the breast. EEG findings showed interictal as well as ictal findings, which localized mainly to the right anterior temporal area, which went well with her clinical symptoms of temporal lobe seizures. This is another EEG that demonstrates the ictal onset in the right temporal lobe. This was clinically associated with intact awareness and eyelid fluttering at that time. Over the next 6 months, unfortunately, her condition deteriorated despite receiving IV methylprednisolone with anti-epileptics. Her symptoms continued to progress. She still had the episodic nausea, olfactory hallucinations, progressive memory, cognitive declines, and her seizures frequency continued to increase. She also had focal unaware seizures with different types of automatisms, including a rarely described entity of periictal water drinking. She had increased hypersomnolence. She would sleep 14 to 20 hours and still have unrefreshed sleep. In physical examination, this also progressed, and she started having dysarthria, ataxia. There started to be a mild right facial droop, as well as abnormalities in eye movements and unilateral eyelid ptosis. Her gait severity increased to the point where she needed wheelchair assistance to walk or two-person support. Her anti-epileptics at that time, initially she received levetiracetam. That was eventually not enough. She was placed on phenytoin, a valproic acid. However, due to the side effects of valproic acid, that was stopped. Her recent regimen included these 4 anti-epileptics: lacosamide, lamotrigine, topiramate, and levetiracetam. Regarding immunotherapy type treatment, she received over the course of several months corticosteroid therapy. During acute exacerbations, she would get IV methylpred and followed by prednisone taper. She also received several doses of IVIG, rituximab, and plasma exchange. Each session of plasma exchange was 5 to 7 sessions per course. And comparing these different types of treatments, she responded best to plasma exchange. However, all improvements were either partial or transient. This caused us to inquire deeper into the patient's history, trying to look for any clues we might have missed. And turns out with menstrual history, we found out that she was in fact born without a uterus. This caused us to go back, re-examine abdominal pelvic CT, order some new ones, and with a focus in the pelvic region, we found that she in fact had an absence of uterus and ovaries, and the closer examination of pelvic CT revealed the bilateral inguinal masses. Karyotyping was done at that point and revealed 46XY chromosome, and whole exome sequencing identified SRY positive X-linked androgen insensitivity. These are the images that were taken of the abdominal pelvic region. In A, we can see bilateral inguinal masses with linear rope-like structures that connected until the inguinal canal. This was similar to the gubernaculum seen usually seen in males. In the sagittal section, we could see no uterus. FDG PET was done, and these bilateral inguinal masses were hypermetabolic in nature. So the decision was made to remove and assess this inguinal masses, and bilaterally they were resected. Under histopathology, it showed dysgenic gonads and prepubertal testicular tissue with intermixed ovarian type stroma. There was no signs of neoplasia in either of the masses. Post-gonadectomy, the patient showed some improvement in seizure frequency and severity. There was resolution of the automatisms she experienced. There was improvement in hypersomnolence and more refreshed awakenings. There was enhanced mood. There was also a slight improvement in the memory, although not clinically evident to the patient. She still had exertional fatigue, nausea, ataxia that required her to remain in the wheelchair most of the time, with still persistent cognitive disturbance. So a brief note about anti-MA2 encephalitis. It's quite rare. It's an autoimmune or paraneoplastic inflammatory disorder that affects the limbic system, diencephalon, or brainstem. It can either affect these areas isolated or in combination. And it can be associated with focal seizures or focal to bilateral. There can be excessive daytime sleepiness, eye movement disorders, and SIADH. Our patient had the typical presentation of anti-MA2 encephalitis. More than 90% of these patients either have a tumor at presentation or sometime during follow-up. A tumor may be detected. Commonly in males younger than 45, it's testicular tumors. In those older than 45 or in females, it is lung tumors. Other rare tumors can exist, although much less commonly. For diagnosis, it hinges on detecting anti-MA2 antibodies. This can be done either in serum or CSF. MRI can be helpful to show the different regions affected. EEG can also help identify the epileptic foci. It can also show LPDs. CSF can either be normal or show increased protein concentration, pleocytosis, and even oligoclonal bands. Usually the management, the mainstay of management is resecting the underlying tumor and immunotherapy, including symptomatic therapy with anti-epileptics. Prognosis varies. There's a study which showed about a third of the patients showed some improvement with the tumor resection and immunotherapy, whereas 46% deteriorated. Outcomes that favor improvement, including young male and complete response with initial treatment, as well as very limited CNS involvement. So in conclusion, anti-MA2 encephalitis is a challenging rare disease which poses challenges in diagnosis as well as management. Our case had an overlying additional challenge with the fact that there was an XY gonadal genesis, the diagnosis of which was delayed and could have hindered the initiation of appropriate treatment and removing of the dysgenic gonads. In our case, genetic testing was important, as well as going back and re-examining the abdominal images and taking the appropriate steps. Unfortunately, our patient, despite multiple repeated immunotherapy, different combination of anti-epileptics, and even surgery, her improvement were only minimal and did not affect her quality of life significantly enough. Further research is needed in this area to develop more appropriate treatment strategies, which can hopefully help patients similar to our own. And this is my reference regarding the last part of my talk. Thank you very much.
I'm delighted to join the International Conference on Neuroscience and Neurology. I would like to thank Scientix Conferences. I would like to share with you my topic entitled Probiotics and Prebiotics as Cognitive Enhancers. I'm Dr. Shireen Abdelmesih, Lecturer of Medical Pharmacology, Faculty of Medicine, Qasr Al Aini, Cairo University, Cairo. What are cognitive functions? Cognitive functions include anything you can do, from attention to memorizing, to speaking, listening, feeling, up to problems. Cognitive impairment might not start as an overt or symptomatic illness. It might start as a preclinical incident. This might be due to mild neurodegenerative changes in the brain. So the patient and or caregivers might not notice any significant change in lifestyle or life activities. Then the preclinical stage will proceed to the mild cognitive impairment, in which the patient and or his or her family might notice minute changes in complex skills, but the patient or the male or female can still execute the normal daily activities. Then the cognitive impairment proceeds to dementia. And dementia, according to severity, can be classified into mild, moderate, moderately severe, and severe. And in dementia, there is actually a symptomatic affection of the daily abilities to fulfill commitments to work or even normal life events. We know that females are more affected than males with cognitive impairment, and many neuropsychological disorders are associated with cognitive impairment, including major depressive disorder, Parkinson's disease, autism spectrum disorder, and other neuropsychological disorders, schizophrenia, bipolar disorder. All these disorders are associated with some sort of cognitive impairment. And here we can track the patient affection of memory, attention, language, etc., with simple questionnaire. Glogate was recently found or suggested as a surrogate marker of cognitive impairment. What about the link between cholesterol and cognition? Unfortunately, most of our happy or lovable meals contain harmful cholesterol. This illustration shows that the LDL or low density lipoproteins are actually the harmful type of cholesterol, delivering or accumulating cholesterol inside our tissues, leading to susceptibility to thrombogenic and atherogenic disorders. While the high density lipoproteins is the protective one, which helps our cells to get rid of excess cholesterol, delivering it to the liver. So liver affection can lead to dyslipidemia or disturbed balance between LDL and HDL. That's why in laboratory testing, ratio between LDL and HDL is a very important marker to rule out cardiovascular risk. Decreased cholesterol and HDL against increased triglycerides, LDL, and LDL-HDL ratio were actually linked to cognitive impairment, affecting synaptic transmission and neuroplasticity. And this dyslipidemic feature affects mainly the verbal domain of cognition and was one of the precipitating factors of vascular dementia and Alzheimer's disease. Depression, major depressive disorder, also was linked to dyslipidemia. And diseases associated with dyslipidemia, including diabetes mellitus, cardiovascular disorder, and hypertension, were also associated with some cognitive impairment and higher susceptibility to depression. The ratio between LDL and HDL was negatively correlated to cognitive scores. In depression, the favorable effect of HDL over cognition was mitigated. What about apolipoprotein E? Apolipoprotein E is another form of protein carrying lipids, and we have many variants of the apolipoprotein. The most common variant is apolipoprotein E epsilon 3, but the most harmful variant is apolipoprotein E epsilon 4, and those carriers of apolipoprotein E epsilon 4 might have 14 or 33 folds higher prevalence to develop Alzheimer's disease, depending on presence of 2 or 1 copy of genetic variant. Female are still more susceptible to cognitive impairment if carrying the ApoE epsilon 4 variant. And many gross and microscopic derangements were associated with carrier of ApoE epsilon 4, including smaller hippocampal and gray matter volumes, more extensive white matter lesions, loss of myelin, changes in lipid components of brain tracts, possession of beta amyloid, microglial reactivity, neuroinflammation, reduced vascularity, and breakdown of blood-brain barrier. What about statins? And statins are known anti-dyslipidemic medications and are first line in the primary prevention of coronary heart disease and ischemic stroke. Statins are known to lower low density lipoprotein, cholesterol, and triglycerides against increasing the beneficial or protective high density lipoprotein cholesterol. Apart from its anti-dyslipidemic activity, statins also exert antioxidant, anti-inflammatory, and anti-thrombogenic activities. Here we can find multiple classifications of members of statins. We have the lipophilic against the hydrophilic ones. In studies linking statins to impaired cognition, found or claimed that lipophilic members trigger more cognitive impairment than hydrophilic members. Also, high intensity fulfilling more reduction of LDL cholesterol were associated with more cognitive impairment than the low density ones, and this was also a dose-dependent effect. Most of statins with long half-life can be administered any time of the day, because we know that cholesterol metabolism occurs mainly in the morning, while the short half-life are either administered in the evening or as extended release formulations. Many previous studies demonstrated the link between statins and cognitive improvement, reducing the risk of dementia, especially in white women and Hispanic men. Also, this was related to adjustments of ApoE lipoprotein, and meta-analysis of observational and randomized control trials, as well as retrospective cohort studies, emphasize the correlation between statins and cognitive improvement. In contrast, some studies reported that statins might be or might trigger cognitive impairment, including placebo-controlled phase 3, double-blind randomized controlled trials. However, meta-analysis and systematic reviews demonstrated no significant difference whether the statin was lipophilic or not, and independent of the duration, location, and previous cognitive status. In the Naranjo Adverse Drug Reaction Probability Scale, there was a probably or definitely related to statins in 75% of reports noticing cognitive impairment, and this was related to previous or underlying behavioral conditions. What about the dietary manipulation of cognition? Can we improve or adversely affect cognition using diet? Actually, many studies demonstrated the answer with yes. For instance, vitamin D3 and omega-3 can improve cognition, and these are some of the foods rich in omega-3 and vitamin D3, including wild salmon, avocados, freshly brewed tea, whole grains, pomegranate, dark chocolate, nuts and seeds, and blueberries. What about probiotics and prebiotics? Let's first define what are pro and prebiotics. Probiotics are actually live, non-pathogenic bacteria and can be supplemented in food, including yogurt and other dairy products. Among these bacteria, we have the lactobacillus, bifidobacterium, enterococci, streptococci, lactococci, pediococcus, and propionibacterium. Prebiotics are not the live bacteria themselves, but are actually indigestible substance, mostly polysaccharides. We have also polyphenols and polypeptide polymers that boost the growth and multiplication of bacteria. And they can be found in whole grains, bananas, onions, garlic, fruit juice, black raspberries, and blueberries. Probiotics compete with pathogenic bacteria in gastrointestinal tract. They stimulate the production of mucin proteins and tight junction proteins, supporting the integrity of intestinal barrier, detoxify xenobiotics and mycotoxins, support the synthesis of vitamin K, riboflavin, and folate. And we know the importance of folate for neuronal synthesis and maturation, and ferment undigested fibers in colon. Probiotics can be supplied in dairy products, in bread, beverages, and baking products, and are now synthesized using the nanoencapsulation, nanoliposomes, and metaphenolic network-based nanocoating techniques. Many preclinical and clinical trials demonstrated health benefits of probiotics, including beneficial role in hypertension and here in reducing hypercholesterolemia in male mice by using Lactobacillus casei, plantarum, and fermentum genus of bacteria. In humans, they were associated with reduction or improvement of the antibiotic-associated diarrhea. Prebiotics, on the other side, are not limited to carbohydrate, as we said before. They might include polyphenols and polypeptide polymers, and their beneficial effects are not limited to GIT, but extends to systemic effects by regulating immunity, influencing metabolism, increasing mineral absorption, lowering blood lipids level, which is relevant to our topic today, and especially of the prebiotics, short-chain fatty acids, including acetate, butyrate, and propionate, were demonstrated to support the health of gastrointestinal tract and brain functions. So what is the link between boosting or supporting the gut and the brain? Actually, the gut and the brain were communicated at multiple levels, including immune system, tryptophan metabolism. Tryptophan is a precursor of serotonin, or the so-called hormone of happiness, and supporting the vagus and enteric nervous system. Microbial metabolites, including short-chain fatty acids, branched-chain amino acids, and peptidoglycans, support many of brain functions, and many neurotransmitters are actually synthesized in the GIT, including also short-chain fatty acids, carbohydrate fermentation products, dopamine, and serotonin. Many brain functions were influenced positively with the administration of probiotics, including mood regulation, neuromuscular function, emotional centers, hypothalamic pituitary adrenal axis, and cognitive centers. Disturbance of gut microbiota or dysbiosis was found to disturb monoamine levels. Monoamines are dopamine and noradrenaline neurotransmitters, thus impairing the hypothalamic pituitary adrenal axis, an important axis in accommodation towards stressful events. And this disturbance was linked to reduced brain-derived neurotrophic factor, an important factor in neuronal repair and regeneration, thus precipitating major depressive disorder. Incomplete or interruption of the gut barrier was associated with abnormal urinary levels of short-chain fatty acid, lipopolysaccharides, and indoles, and this actually was found with autistic spectrum disorder. Increased intestinal permeability as well as immune activation was linked to impaired function of the blood-brain barrier, neuronal loss, and neuroinflammation in Alzheimer's disease. In contrast, the administration of probiotics, especially butyric acid, one of the short-chain fatty acids, was found to support or increase the brain-derived neurotrophic factor, mediating an antidepressant activity in animal models. Also, this was demonstrated in humans using the back depression inventory index, and improvement in major depressive disorders was associated with decreased insulin level. Actually, we don't know exactly whether increased or decreased insulin can precipitate depression or not. This remains controversial up till the moment. What is the link between prebiotics and probiotics? As mentioned before, prebiotics promote the development of probiotics and are major source of carbon for metabolism of probiotics. Polysaccharide from brown seaweed, compressor, enhance the growth of bifidobacterium and lactobacillus. These bacteria produce short-chain fatty acid mediating inulin-like effects. Inulin-like effects including anti-inflammatory and anti-apoptotic effects. The antibiotic-induced dysbiosis was actually associated with altered brain-derived neurotrophic factor, gamma-aminobutyric acid, a major CNS inhibitor, N-methyl aspartate, an important glutamate receptor, and tryptophan. Altered gut microbiota was associated with diseases linked to cognitive dysfunction, including Parkinson's disease, major depressive disorder, Alzheimer's disease, and schizophrenia. Using probiotics in normal rats, whether single type of bacteria or multi-strain, triggered positive effects on spatial and non-spatial memory. Animal models of diabetes mellitus, Parkinson's disease, and anxiety showed improvement in cognitive defects upon administration of probiotics. Some other studies in normal animals and humans did not show such beneficial effects. Concerning humans, in aging populations, there was promising outcomes in mild cognitive impairment and Alzheimer's disease. Early intervention with probiotics at age younger than 13 years old demonstrated less prominent effects on neurocognitive development, but reduced the risk of attention deficit hyperkinetic disorder and autism spectrum disorder. These beneficial effects were not actually prominent concerning healthy humans, and introduction of single-strain probiotics exerted more benefits versus the multi-strain components. Prebiotics exerted also beneficial activity over cognitive disability by inducing the growth of bifidobacterium and lactobacillus genera, producing potentially beneficial effects in autistic spectrum disorder and attention deficit hyperkinetic disorder. Administration of prebiotics early in life till adolescence caused the growth and expansion of gut microbiota and was associated with enhanced development of neuronal synapses. Human milk was demonstrated to supply or provide oligosaccharides, stimulating the growth of beneficial gut bacteria. Prebiotic-fed mice demonstrated reduced stress-induced anxiety, and stress-induced anxiety is one of the precipitating factors of cognitive impairment. The administration of prebiotics in mouse model of autism spectrum disorder and Parkinson's disease were associated with enhanced cognitive function by multiple mechanisms, including increased reduced immune response, reduced inflammation, and reduction of cognitive deficits. In children, whether boys or girls, who were obese or overweight, administration of oligofructose enriched inulin improved appetite, reduced energy intake. This was more prominent in older children. In preterm infants admitted to level 3 ICU, the administration of prebiotics such as short-chain galacto-oligosaccharides, long-chain fructose oligosaccharides, and pectin-derived acidic oligosaccharides were associated with a higher cytokine level relevant to inflammation and lower neurodevelopment and 24 months of age, while short-term enteral prebiotic had no effect on neurodevelopment during first year of life. Here we can find that there are controversies and discrepancies as regards the beneficial effects of prebiotics in human studies. In contrast, in healthy adults, male or females, the administration of galacto-oligosaccharides reduce the waking cortisol response, indicating reduced depression, and decreased vigilance to negative information, signifying reduced anxiety and depression. The administration of prebiotics by boosting the growth of bifidobacterium longum showed improvement in multiple cognitive domains in patients with cirrhotic liver. Symbiotics are actually a combination of prebiotics and probiotics. As we can see here, the administration of probiotic in the form of bifidobacterium longum and lactobacillus rhamnosus, as well as prebiotics in the form of inulin and fructose oligosaccharides and long-chain polyunsaturated fatty acids in 12-month-old toddlers were associated with higher changes in cognition between 12 and 16 months of age. However, this was still non-significant. So what is the link between probiotics, prebiotics, statins, and apostatin? In patients with Alzheimer's disease, there was increased E. coli, decrease short-chain fatty acid inflammation and microglial activation. Also, in patients with Alzheimer's disease, many of them were carriers of ApoE4 and ApoE3. And those carriers of ApoE4 had more extensive gut dysbiosis. Again, the difference in gut microbiome between females and males was claimed to be one cause of high risk of Alzheimer's disease in females. The administration of inulin in female mice carrying the ApoE4 allele altered the beta diversity of gut microbiome, exerted anti-inflammatory effects, decreased the harmful E. coli linked to stroke, traumatic brain injury, and Alzheimer's disease, and normalized the alpha diversity related to age and stroke, reduced lactobacillus related to inflammation and cancer, reduced the pyruvate dehydrogenase, thus delivering more glucose to brain and neurons. It was also demonstrated in mice with traumatic brain injury. The study was replicated also in male mice, and similar results were found whether male or female mice were employed. In also in young mice with the human ApoE3, whether male and female, similar results upon administration of inulin, one of the prebiotics for 16 weeks, was associated with altered gut microbiome and increased availability of glucose to brain and neurons. However, this study did not demonstrate sex-related difference in the effects. In straight downy rats, Lactobacillus acidophilus as a probiotic regulated the expression of intestinal transporters for statins. Here we find that the administration of probiotics actually boost and improve the dynamic of statins and increased rosuvastatin uptake into hepatocytes was also one beneficial effect of the administration of probiotics, and enteric microbiomes were associated with increased bile acids, and this was positively correlated to plasma levels of simvastatin. Also, the bacteroids enriched gut microbiome lead to enhanced response to statins and increased prenol lipid, reducing pathogenic bacteria genera, multiple pathogenic genera, and versus increase the beneficial ones. The administration of rosuvastatin in mice actually altered the gut microbiome, increasing the beneficial versus reducing the harmful ones. This was a study done in Jordan, employing male and female patients with dyslipidemia who were ApoE4 carrier, and these patients showed lower response to statins compared to ApoE3 and 2. There was no sex or age-dependent differences in such effects. Also, the lower effect of statins when administered for 4 weeks was associated with carriers of ApoE4 and ApoE3 patients. Despite the seemingly beneficial effects of probiotics and prebiotics as regards cognitive enhancement, yet most of the studies are short-term, so long-term studies are required to determine the efficacy, safety, and dosing schedules. Current evidence is not sufficient. Studies are lacking, especially those studies tailored to address the nutritional manipulation in presence of different ApoE variants in males and females. In my perspective, a happy meal should support learning, progressing, adapting, communicating, moderating emotions and reactions to stressful events, creating and taking initiatives to achieve and develop solutions for life issues. So a happy meal should be a healthy one, 1 week ago, we celebrated in Egypt a feast called Nasim in English, like smelling air breeze. In this feast, we usually consume colored eggs and salted fish. I think the ancient Egyptians were able to consume one happy meal at least one day of the year. Thank you. I appreciate your attentiveness.
Okay, hello everyone. I am Golnaz Baghdadi. I'm joining you today from Iran. I studied biomedical engineering, and my presentation is about brain network desynchronization in the face of attentional demands using a mathematical model. As you know, in attention demanding task, your bottom-up and top-down controller are activated. The bottom-up controller is sensitive to a stimulus, and it is involuntary, fast, and involves low-level sensory regions. And your top-down controller is goal-based, and it is voluntary, and it is a high-level controlling regions like the frontal lobe. And in facing with distractors, distractors can slow your response time due to resource shifting in your brain. And the top-down controller is responsible for suppressing distractor effects and enhancing the target responses. Neurocognitive studies show that there is an interaction between bottom-up and top-down processor, or bottom-up or top-down attention, and during attentional task, it was observed that desynchronization and synchronization exist between top-down processors and bottom-up processors. And it is believed that desynchronization can attenuate the activation of non-target processing units, while synchronization between neuronal clusters can enhance the processing of targets. But it is not well known that what is the role of desynchronization in this procedure. And the goal of this study is to investigate the mechanism behind the synchronization and desynchronization in our neuronal activity during attentional tasks. And we want to explore how these mechanisms contribute to target processing enhancement and reducing the distractor effects. For reaching to our goal, we used a mathematical model to simulate the impact of different factors like distractor strengths and similarity between distractor and the target stimulus, and how synchronization and desynchronization phenomena can cause distractor reduction and reduce the negative effects of distractor. The scenario that we used in our model is that there is a target and there is a distractor in the environment, and we expected that the top-down attention can reduce the distractor effect and enhance the target processing using synchronization and desynchronization between top-down and bottom-up processors. Our model, suggested model, includes two main units. One unit was for top-down system, and one unit was for bottom-up system. And the bottom-up system has two subunits. One unit is responsible for or sensitive to the target, and one unit is responsible for processing the distractor. And the input of the model is target and distractors simultaneously. And we want to show that how synchronization and desynchronization between the top-down and bottom-up unit can help us to reduce the effect of distractor and enhance the target processing. This slide shows the mathematical formula of the model. Each row shows the mathematical model of one of the previous unit. The first line shows the mathematical model of the target processing in the bottom-up unit. BUTRG index shows the bottom-up processing target processing unit, and the BU distractor shows the mathematical formula of the distractor processing unit. And the last line shows the the formula for top-down controller. This formula is for shows an oscillator. It's a Van der Pol oscillator that can produce some oscillatory activities, and we represent the stimulus, target, and distractor as a rhythmic or oscillatory activity with the frequency of W and the amplitude of A. That the amplitude shows the strength of the stimulus, target, or distractor, and W is the frequency that codes the stimulus, or the target or distractor. And when we wanted to increase the strength of distractor or strength of the target, we just increase the amplitude of A. And if we want to show the similarity between the distractor and the target, we just use the same frequency, I mean W, in both target and distractor. And to show the influence of top-down attention on bottom-up processing and bottom-up processing on the top-down attention, we use these terms that have both the output of top-down controller and the output of bottom-up processing. And the coefficient of B in all formula shows the influence of top-down attention on bottom-up processing and bottom-up processing on top-down attention. And if we want to increase the effect of top-down attention on bottom-up processing, we just increase these coefficients. The output of these formula and the mathematical model is oscillatory activity that you can see in the right figure. And this oscillatory activity is like different spikes in our neuronal activity. And we just, for a better visualization, we just focus on the envelope of the activity that is shown by the bold blue line in the figure. And we just in next figures, in next results, I just showed the envelope of the activity. That reduction of this envelope shows the reduction of the activity of these units, and the increment of these envelope shows shows an increase in the activity of these neuronal units. In this slide, you can see the output or the envelope of the activity of different units. The green one shows the activity of the top-down unit. The dashed black line shows the activity of distractor sensitive unit, and the blue solid line shows the activity of the target sensitive unit. And this red dotted line shows the threshold. It represents the threshold in our neuronal activity that we want to have. If we have under threshold activity, it shows that it cannot activate the next neuronal clusters or units. And in this figure, we omit or neglect the influence of top-down attention unit. And as you can see, the top-down attention unit has the activity of under threshold activity. But in the neck, and as you can see, both the processors, bottom-up processors, process both target, the black line, and the blue line, and the non-target, I mean distractors, and both units have upper threshold activities. And we want to add the influence of top-down controller to reduce the activity of the distractor sensitive unit. And in the next slide, we added the influence of top-down controller. This line shows the onset of a stimulus. And as you can see, in the time near 20, the stimulus is presented, both target and distractors. And as you can see, by adding the influence of top-down attention unit, I mean by increasing the coefficient of top-down unit in our mathematical model, we can see that the distractor sensitive unit, the activity of the distractor sensitive unit starts to decrease by influence of top-down attention. In our model, top-down attention sends some desynchronous signals into the bottom-up attention system, bottom-up units, and cause them to be desynchronized and reduce the effect of distractor in the model. By increasing the top-down attention, the effect of top-down attention unit, I mean by increasing the coefficients of top-down attention in the mathematical model, we can see that the activity of distractor processing reduced faster than before. In this slide, we try to increase the strength of distractor by increasing its amplitude in the mathematical model. And as we can see, top-down, even by the influence of top-down attention, we couldn't decrease the activity of distractor, which is shown by the black dashed line, and we couldn't decrease it under the threshold because the strength of the distractor is high, and the top-down attention cannot overcome the bottom-up processing, and bottom-up attention in this scenario is dominant and can attract our attention to the distractor because of its higher strength. And in this slide, we tried to show this, show how the similarity between distractor and target can affect the influence of top-down attention and the desynchronous and synchronous phenomena. And as you can see, by increasing the similarity between target and distractor, we couldn't be successful in reducing the effect of distractors on our bottom-up processing unit, and the activity of distractor sensitive units is higher the threshold, but it is oscillatory envelope. Because the similarity, most of the time, the similarity between target and distractors can confuse us in selecting the target instead of distractor. And the model confirms this phenomena. As a conclusion, our model highlights the significance of synchronization and desynchronization in target processing enhancement and the distractor suppression. And we can see that by sending some desynchronous signal from top-down attention to the bottom-up processors, like jamming signal, we can desynchronize the activity of bottom-up processing units, and our model mathematically shows these phenomena that we observed in neuronal recording. And we can see that desynchronous can use to reduce the activity of neuronal clusters or neuronal units that are sensitive to distractors, while using synchronous signals from top-down attention to the bottom-up processing can enhance the target processing activities. And our model outcomes confirm and support the adaptive resonance theory that was proposed by Professor Grasberg. And this adaptive resonance theory predicts that synchronization and desynchronization is the basic or the basis of our cognitive function. And we can, in our model output, we can see that how these two phenomena, I mean synchronization and desynchronization, can help us to reduce the effect of negative effect of distractor and enhance the positive effect of targets. And adaptive resonance art theory also proposes that neuronal processors can adapt through synchronization or desynchronization between the different regions of our brain and can influence our attentional mechanism. And the output of our model confirmed this, the prediction of this theory, and shows that how desynchronization and synchronization can help us in these attentional demanding tasks. And also the model shows how some factors, influencing factors such as the intensity of the stimuli and or the similarity between target and distractor can affect the synchronization and desynchronization processors that we previously observed in our neuronal recordings. And it shows that synchronization and desynchronization dynamics, as suggested by Art, play an essential role in attentional control system and distraction suppression. The model also predicts that the inter-individual variability or between individuals variability can be related to the effect of synchronization and desynchronization phenomena, but because different people may have different level of a neurotransmitter that is presented by the coefficients B and A in our model, and considering different coefficients, we can represent the inter-individual variability or between individual variability.
Thank you for this introduction about me, and I am working to make the conference a success and it contribute, and I am very happy to participate to this grateful conference from Iraq, Nineveh University. Is the voice clear? And the slide is clear or not?
Yes, it's completely perfect.
Yeah. Okay. My literature, my presentation now. My article, the first slide about the evaluation of the cytotoxic effect of the metformin on a variety of cancer cell line. Now, we give an introduction about the cancer. The cancer is a dangerous disease that introducing by environmental influence, producing a mutation gene involved the cell growth regulation defined by inability to control. Cell proliferation is happening uncontrolled cell activity, which is affected in the surrounding tissue that is result in the cell proliferation. Okay, next slide. Talk about the metformin. Metformin, we all know the anti-diabetic effect or anti-diabetic drug have the effect on diabetic disease. Now, the gold stone about this article and how to introducing the metformin and can be all the drug in a new application. They many studies extensively and include interaction pathway in tissue that lead to insulin resistance. Metformin mechanism as an anti-cancer is maybe suggest that cancer proliferation inhibiting the mammalian targeting on the mTORC. mTOR protein kinase, the receptor secreting the protein makeup of mTORC is a multi-protein complex. Now, the cancer is the dangerous disease we inducing by environmental. We know the treatment by anti-cancer drug. But the aim of my study or my article or my research to access the percentage viability to identify the cytotoxic effect if metformin have a cytotoxic effect or not on different cell growth line, such as here cervical cancer, such as the liver cancer, such as breast cancer, AMG 13, and in vitro with the normal cell. طبعا all of these may be as a cell line. This is the name of cell line. And to compare with the IC15 of metformin in cancer and with the normal cell. Now, the material and method of my article, maintaining the cell culture line in cancer cell in Iraqi biotechnical cell bank provided by human cervical cancer cell and liver cancer cell line and the normal human breast cancer and the brain cancer, glaucoma and malignant brain tumor And the new breast cancer that is maybe diagnosed newly in Iraq, AMG 13, that is the cell line new in Iraq discovered. All cells are kept in prime supplement with 10% of fetal biofilm and 100% units per ml of penicillin to prevent or to avoid the contaminated, and 100 gram to ml of streptomycin.
Sorry to actually interrupt, but you have to keep on like changing your slides during the talk, and your slides are not moving. We are still seeing the first slide.
I am sorry.
No worries.
Please
Sorry
give
to-
me 1 minute.
Please
Okay,
continue.
I'm sorry.
You can put it on the slideshow. Yeah, that's
Now,
perfect.
okay, this is right?
Yeah,
Yes,
that's
okay.
perfect.
Thank you very much for the attention. Yes, the material and method, the maintenance of the cell culture lines of the normal culture that all cancer cells can be obtained from the Iraqi biotechnic cell bank provided by human cervical, breast cancer, and brain cancer cell. All of this line may be contributed to access if the metformin have a cytotoxic effect on this cell. And after that, we comparing with the normal cell, human cell line, HB100, that is kept in the biotechnician in a bank in Iraq. Okay, all kept in environmental that is maybe supplied with 10% of vital provan and 100 units of ml of penicillin, and with 100 gram per ml of streptomycin, and with EDT. All these substance to supply the nutrition media and the nutrition site to the cell to maintain the growth. Okay. The cytotoxic assay. How to do the cytotoxic assay? We take the concentrations of metformin from 0, 5, 10, 25, 35, 45, 65, and 130 micromole. Of all these concentration, we applied it to the all these lines, all these cancer cell line, and do normal to compare if they may be effect on normal and effect on the cancer, this cancer cell line. Okay. Now, in this result, we show in this figure the cytotoxic effect of metformin on breast cancer. We show the MTTA assay in here, incubated for the 45 and 72 hour with the concentration that's wide range of concentration from that range from the 0 to the 113 micromole concentration of metformin. We show in this figure the cytotoxic effect of metformin that is maybe effective after 72 hours and maybe effective in the high concentration, that's 130 micromole. That is mean the concentration cytotoxic effect of the metformin is maybe time and dose dependent manner. Okay, we show the figure 2 that is showed the cytotoxic effect of metformin in dose and time dependent manner on variability طبعا to 31% at 48, while the 72 hour maybe increased cytotoxic effect of the metformin. That is mean is increasing the time and increasing the concentration, maybe the more cytotoxic effect in this cancer cell line. Now, in the liver cancer cell, we show the effect of the cytotoxic maybe less than cervical and the breast. Okay. And in brain cancer cell line, we show the higher concentration of metformin demonstrated higher significant decrease in viability when compared between the IC15 of the all cancer cell line with the normal. We showed effect on the HELIA, that is in cervical cancer, that is show the significant and higher effect, cytotoxic effect of this cancer cell line. Now we're concluding from this result the potential cytotoxic effect of metformin in the cervical cancer cell when comparing with the normal. We show the IC15 is in the HELIA or the cervical is maybe high. That is mean is can be concluded that the metformin can be used with a regime of anti-cancer in cervical in cervical cancer can be used or can be added. Conclude of current study that highly significant selective cytotoxic effect. Now, we show the selectivity of cytotoxic effect of metformin. That is mean the effect of metformin as a molecular mechanism, not in general as is effect of the gluconeogenesis. No, not this pathway. Effect is as a molecular effect when when completed the research, we show the gene expression may be different from cervical, and the metformin can be actually cytotoxic effect on this cervical cancer, and lesser effect on breast cancer and liver cancer, were the least effective effect and cytotoxic effect on the brain cancer than the normal cell. Thank you.
Greetings of the day. I hope you are doing well. Thank you for your invitation to participate in the second international webinar on neuroscience and neurology. My name is Dr. Ardalan Shariat from Department of Digital Health, School of Medicine, Tehran University of Medical Sciences, located in capital of Iran. The title of my presentation would be about effectiveness of tele-rehabilitation, a motor and social skill among children with neurodevelopmental disorder. Before I started, I wanted to say that this day one of the problem, not only in developing countries but also in developed countries, is about their children. The health of their children is normally affected by environmental parameters, family parameters, and also genetic parameters. So it's very complicated to solve all of those together. And also the families are very stressful and they are worried about future of their children. In addition, if for any kinds of therapy you will go and see the doctor or physician, it takes too much time and also is too costly. So we were thinking how we can prepare the results of other research down about this topic. I think it's not bad to make a definition about telerehabilitation. What's telerehabilitation? Actually, telerehabilitation is the ability to provide assessment and intervention to people who require rehabilitative services via telecommunication. Telecommunication means it could be done using WhatsApp, using Skype, or any kind of online platforms. Neurodevelopmental disorders, that the abbreviation would be NDD, alter the development of the nervous system, causing a variety of effects, which include alterations in emotional behavior, learning ability, self-control, and memory. These disorders include variations in level of impairment of the brain maturation process. So it means there is a very wide variety of neurodevelopmental disorder. According to the American Psychiatric Association, attention deficit or hyperactivity disorder, which could be called ADHD, autism spectrum disorder, which we call ASD, developmental coordination disorder, and cerebral palsy are included within the global diagnosis of ND. These impairments persist throughout development and may continue throughout life. What it means? It means this problem maybe will be remain with the children during their whole life. It's very painful. It's very painful that a family should see their child with this problem during the whole life. So what it means? It means it's very important recognize about this problem in earlier stage and start the therapy. There are several suggestions for doing exercise and other kinds of therapies and consultations, but most of them are expensive to do. You know, there are sometimes different kinds of suggestions, but it's very important to know all those useful for all the children or all those useful for the whole family, because the suggestion should be useful not only for one kind or two group of family. It should be feasible and it should be cost benefit to be done for any family, any children in any parts of the world. So using from online platforms with lower cost in time and also money could be useful and cost beneficial, not only for the patients and their families, but also for the therapist. Yeah, once you go through online platforms, the family can pay less, not only in money but also in time, and the therapist also can do visit for number of patients. High number of patients is easier for them, and it's also easy to have access to therapist from any place. For example, if you are living in a low income country, or if you are living in a developing country, you can simply contact with a physician or doctor in any place of the world, just using your phone or just using your laptop. So with care to this point, we have tried to organize a narrative review with a focus on the effectiveness of tele-rehabilitation and motor and social skill among children with neurodevelopmental disorders. So among available databases, PubMed, Scopus, and Web of Science were searched for the English papers published from 2018 to January of 2024. The keywords for this search were telehealth, telemedicine, telerehabilitation, motor, social skills, children, and neurodevelopmental disorder. Finally, among 35 papers inserted in Mendeley, 6 papers were analyzed. Ineligible papers and those papers with unclear methods were excluded. The 6 selected papers had focused on telehealth and improving the social and physical abilities of the children with neurodevelopmental disorders. Most of them had focused on telerehabilitation as a cost-effective way or cost-effective method for improving the health level of the children with neurodevelopmental disorder. As a home message, and based on the findings by the author, the practical role of telehealth for the children was clear and useful, but there is a need for further research to compare the benefits and deficits of using online platforms in comparison with face-to-face therapies. You know, it's very important to consider the deficits. For example, once you are checking or once you have visiting your patient face-to-face, so you can do physical examination. You can feel your patient simply. You can understand his or her feeling. But once you are using online platforms, for sure, you are not able to do any physical examination. It's also difficult to feel your patient simply. So not only we need to do some research about this comparison, but also there is a need to make some educational plans, educational courses for the physician and also for the family as a social education, because once the family know how they can use online platforms and how they have to report the problems, and also our physician know about ethics, how I have to respect to the requests of my patient, or how I have to respect to security of my patient, so the process would be easier and more feasible for everyone. Here I have just included some of the references used in this research. I hope this topic be as a light in your mind and you start to do some research not only about tele-rehabilitation but also other aspects of rehabilitation for the children with neurodevelopmental disorders. Thank you very much for your attention.